Hello and welcome to another edition of the NeuroOp Guru. I'm here with my good friend, Dr. Drew Carey. Hi, Drew.
Hey, Andy.
And today we're going to be talking about the risk of ischemic stroke in non-arteritic anterior ischemic optic NAION, NION. And so, Drew, maybe you could just fill us in on the background of why this is important.
Absolutely. So NAION, or non-arteritic anterior ischemic optic neuropathy, some people refer to it as NAION or NION, is the most common cause of acute vision loss due to an optic neuropathy in somebody over age 50. And it's caused by an episode of poor blood flow to the optic nerve in the anterior aspect or the intraocular portion, so the optic disc or optic nerve head. And when patients come in acutely, we can see that the nerve is swollen, and that's how we know it's an anterior ischemic optic neuropathy. It occurs most commonly in people over age 50 who have at least one underlying vascular risk factor, things like high blood pressure, high cholesterol, diabetes, sleep apnea. But it's not thought in most cases to be embolic, rather due to hypoperfusion and small vessel disease. And in the past, some doctors have recommended that patients should be on aspirin because this is a type of a stroke and they're maybe at risk of other strokes. But aspirin really hasn't been shown to help to reduce the risk of having a recurrent NION event. And most people practicing in neuro-ophthalmology, don't treat these as acute strokes. We don't send these patients to the hospital for stat neuroimaging and stroke workups. But the question kind of remains, are these patients at increased risk of stroke, and should they have some type of stroke modification, risk factor modification done to reduce their risk of other vascular diseases like heart attack and stroke if they've had an NAION event?
And so, what did this study do in terms of methods?
Yeah, so this was a retrospective study, and they looked at HMO databases of 800,000 patients. And the benefit there is if you're inside an HMO, they're going to have all your records. So it's not like you're going to be seen for NAION at hospital A and then have a stroke at hospital B and not have that connection linked. So that's the major benefit to using this type of database. And they looked at patients who had an incident NAION event and then looked at the patient and control patients with risk factors and without vascular risk factors, and they stratified those NAION patients into those with risk factors and those without risk factors, and then followed them to see which patients went on to had stroke over time, and used some survival statistics to look at that.
And what is it that they found?
So they found 605 patients with NAION, which is a lot because this is only about a 1 in 12,000 event. So you'd have to look at a lot of patients, which is why they used a large database. And as we often see, 53% of the patients with NAION were men, and they had a mean age of 64.5 years. So in neuro-ophthalmology, we would look at this and say, yep, those are the type of NAION patients I often see. And they found that there was an increased risk of both large vessel stroke as well as small vessel strokes in the NAION group compared to the controls. But they did not see a difference in cardioembolic strokes. So those due to like atrial fibrillation or PFO, which makes sense because we don't typically think of NAION as an embolic disease.
And is your recommendation based on this study that people have a carotid evaluation?
When I first started, I did recommend patients get carotid evaluations, and then they all came back kind of normal. And NAION's not really a carotid, not an embolic disease. And so I stopped. But now I think maybe we should be doing carotid evaluations because these patients did have increased risk of large vessel disease and carotid artery disease. It was about a 4% increase absolute risk for the large vessel strokes, while the small vessel strokes was only like a 1.5% absolute risk increase. So I do think that is reasonable. I think, we have to keep in mind that just because it's like 50% stenosis, I wouldn't necessarily recommend that they need to have surgery for that because this isn't necessarily a carotid embolic event the way that central retinal artery occlusion is. But I think it's probably important that we're evaluating the patients because they are at increased risk.
What do you think this is the take-home message for our audience for this study?
So I think the take home message is remember that NION is a stroke of the optic nerve. We don't typically think of it as a brain stroke equivalent the same way we do about retinal artery occlusion is a brain stroke. And so they don't need acute stroke evaluation, but it is certainly reasonable and probably a good idea for the long-term health of our patients to make sure that they are getting those stroke risk factors evaluated and optimized to reduce their risk of long-term stroke and disability from that.
And does the link to large vessel disease change your decision making on aspirin?
I don't know that I would recommend aspirin specifically for a patient who had NAION if they did not have other indicators for it. I think using like the 10-year ASCVD calculator is probably more appropriate than just pan recommendation for aspirin because there are risks. And also for many patients, the benefit to aspirin in just patients over 50 is very limited. So I think appropriate targeting based on a holistic evaluation is appropriate.
Well, thank you again, Dr. Carey. This concludes yet another edition of the NeuroOp Guru.
Thanks, Andy.